Hello all, I'm Mohammed Rayan of 40th Listers. So today we'll be discussing about Parkinsonism. Let's start the class by looking at a clinical scenario. That is, a 69-year-old man went to consult his physician. He had tremors in his hands and fingers. His face was unexpressive. When he was invited to enter the physician's office, he had difficulty in standing up. He walked slowly into the office, and there was no sensory loss. The stretch reflexes were normal, and the muscles exhibited rigidity. Identify this condition, discuss the physiological basis of this condition, describe the connections of basal ganglia, and discuss the functions of basal ganglia. So in this question, let's look at the certain features the patient is exhibiting. That is, there is tremors in his hands and his face was unexpressive. And also, he had difficulty in standing up. That is, he had difficulty in initiating a movement. And also, he's walking very slowly. And also, his muscles exhibited rigidity. So these are the features suggestive of Parkinsonism. So in this session, we will look on the Parkinsonism. And in another video, we will discuss about the connections and functions of basal ganglia. So first of all, Parkinsonism, it is an extrapyramidal motor disorder. So it is a motor disorder and it is also extrapyramidal. So that is, here there is degeneration of the nigrostrial dopaminergic neurons in the basal ganglia. So the pathology lies in the basal ganglia and there is degeneration of nigrostrial dopaminergic neurons. So as a result of this, there is loss of dopamine and dopamine receptors. Now, what are the causes of Parkinsonism? Parkinsonism can be either idiopathic, that is, the cause is not known, or maybe drug induced, that is, certain drugs like antipsychotics or metoclopramide can precipitate Parkinsonism. And sometimes Parkinsonism, there is increased methyl phenyl pyridinium, that is MPP. It is due to the action of an enzyme called monoamine oxidase B. So MOAB. So there is increased MPP in Parkinsonism. So these three are the usual causes of Parkinsonism. Now let us look at the features of Parkinsonism. So features of Parkinsonism, we can divide it into hypokinetic and hyperkinetic movements. So first let's look at the hypokinetic movement. So first of all, there will be akinesia. That is, in the question we saw that the person was unable to stand up. So akinesia means there is difficulty in initiating a movement. So that is akinesia. And also the patient will have bradykinesia, that is slowing of movements. All the movements of the patient will be slowed, not like a normal person. He will be doing it in very slow manner. That is in the case, previous case also we saw that there is slow walking and also there is slowness of movement. And another hypokinetic feature is decreased associated movements. That is, a normal man when walks will swing his hands and all. So in Parkinsonism, the patients will not be swinging his hands. That is decreased associated movements. And also, the patient will have a mask-like face. That is expression-like face. So that is what we saw in the clinical case. So if we get a question with expressionless face or mask like face, then there is bradykinesia or akinesia, then we can think of Parkinsonism. Then another hypokinetic feature is serpentine stare. That is, the frequency of blink is reduced. So the frequency of blinking is reduced. That is called serpentine stare. And a clinical sign that is called a Meyerson sign is elicited. That is, while tapping on the glabella continuously, blink response is seen. So that is Meyerson sign. So that these are the hypokinetic movements of the in Parkinsonism. Now hyperkinetic movements. So hyperkinetic movement, first one is rigidity. So rigidity means here there is motor neuron discharge is increased to both agonist and antagonist. So as a result of that, there is rigidity. So in Parkinson's, the common rigidity is lead pipe rigidity. That is, there is the limbs will resist the passive movements. So this type of rigidity is called a lead pipe rigidity, and it is common in Parkinson's. That is, the limbs will resist the passive movement. And sometimes the patient may exhibit cogwheel type of rigidity. That is a catching during movement. So that is a catching type of rigidity during movement is called cogwheel rigidity, and it is sometimes seen in Parkinson's. And one important point you need to notice that there is no clasp knife rigidity in Parkinson's. So that is, there is no clasp knife rigidity in Parkinson's. So the rigidity in Parkinsonism is lead pipe rigidity and cogwheel rigidity. Now the tremor. Next hyperkinetic feature is tremor. So in Parkinsonism, tremor is during resting, so it is called a resting tremor. That is, even at rest there is tremor. In cerebellar lesions and all, we saw tremor during doing certain thing, that is intentional tremor and all. Here there is resting tremor, and also it is a pill rolling type of tremor. Now about the gait in Parkinsonism. In Parkinsonism, the gait is called fascinant type of gait. That is, the patient will try to catch the center of the gravity. So in this picture, you can see that is the fascinant type of gait. That is, the patient is just like trying to catch the center of gravity. That is a stooping posture. Now let's look at the management of Parkinsonism. That is the treatment of Parkinsonism. The drug of choice is levodopa and carbidopa combination. That is a levodopa and carbidopa combination. We must note that here we are using a combination of levodopa and carbidopa. We are not using dopamine alone, because dopamine cannot cross the blood-brain barrier. So if we give dopamine, then it is of no use. So that is why we are giving levodopa. Levodopa can cross the blood-brain barrier. Then why are we giving carbidopa along with levodopa? We are giving carbidopa because to prevent the peripheral conversion of levodopa into dopamine. That is, in periphery the levodopa is converted into dopamine. To prevent that, we are giving carbidopa. So, and also carbidopa also functions by reducing the adverse effects of levodopa. Now another drug is centrally acting anticholinergic. Actually, it is the drug of choice in drug-induced Parkinsonism. That is centrally acting anticholinergics are used. Then monoamine oxidase B inhibitors are used. Example dipyrinil, and also sometimes glomus cell transplantation, and all these type of other modalities are used in treatment. So basically, the most important thing you need to note about treatment is this levodopa and carbidopa.